and in today's session I'm going to discuss about management of medically compromised patient in oral surgery. Now, a thorough knowledge of patient complete medical history is very important when you're treating the patient both preoperatively and postoperatively. Now, this can only be done when you take a proper case history of the patient, wherein you ask the patient regarding the systemic disease, if the patient is on any kind of medication, the duration of medication, the number of medication the patient is taking, and how long the patient is into this medical condition. Now, before we move on to the management of medically compromised patient, I would like to discuss regarding the classification given by American Society of Anesthesiologists. They classify the physical state of a medically compromised patient, whether and their risk level and their medical risk level undergoing surgical procedure, wherein ASA1 is a systemically stable patient, does not have any kind of systemic disease. ASA2 is mild systemic disease. ASA3 is severe systemic disease, but it is not incapacitating. It is limiting the activity, but it is not incapacitating. ASA4 is severe systemic disease that is incapacitating and the patient is on constant threat to life. Then ASA5 is the patient is not expected to survive more than 24 hours if it is not undergone into surgery. ASAE is emergency procedure of any kind. When you are listing this, ASAE always come before any of the ASAs. Okay, because this is an emergency procedure. Then you will classify them as ASA1, ASA2 or 3. Okay, let's begin with the first medical condition, that is hypertension. Now, hypertension is nothing but a persistent elevation of blood pressure more than 120 by 90 mmHg. We're all aware that a normal blood pressure is 120 by 80 mmHg. So a patient comes to you from your clinic and the patient is delayed for your appointment. He's coming, running and rushing and comes to your clinic and you measure the BP. And the BP turn out to be at a higher level, that is suppose 150 by, you can say 100 mmHg. That is not considered as hypertension. Wait, ask the patient to sit for a while, then after 15 minutes measure the BP. It is around 140 to 90 mmHg. Then you again repeat this procedure after 15 minutes. Suppose it comes out to be 120 by 90. That means the patient was apprehensive, was in a hurry and under stress. That's the reason why the BP is elevated. But if the patient is at normal but at recurrent interval, after every 15 or half an hour you check the BP and it is coming elevated, then you term that patient as a hypertensive patient. Okay, controlled hypertensive patient who are on medication, no need to worry. But uncontrolled hypertension is a problem. Now they reflect the cardiac status of the patient and they are at higher risk of anesthetic risk. Now, because of elevated high blood pressure, there is excessive of bleeding from the operation site, which will complicate the surgical procedure. And at the same time, there will be significant amount of blood loss. Now, what are the preoperative investigation that you need to do for these patients? For any patient who is undergoing a general anesthesia procedure, chest X-ray is a must. With the chest X-ray, you will come to know any kind of abnormality that is present in the cardiac system or in the respiratory system. Do an ECG. Check the that is T wave inversions or peak of the R wave, S wave and all. Then optical evaluation for papilloedema and retinal hemorrhage and renal function test. Now, what are the preoperative medical management that is required? Monitor a morning dose of medication prior to surgery should be given with sips of water. Normally what happens under general anesthesia, we keep the patient NBM. But in case the patient is hypertensive, you will give the morning dose of medicine with sips of water. You will monitor the vital both intraoperatively and preoperatively. If the patients are on diuretics, you will postoperatively give IV potassium supplements. And in case you're doing a procedure in local anesthesia, you will avoid LA with adrenaline. Rather than you will use plain LA, or instead of that you can use bupivacaine, a longer acting local anesthetic. Let's move on to the patient that are on long-term anticoagulant and antiplatelets. Now, condition wherein anticoagulants therapy is used, that is deep vein thrombosis, arterial fibrillation, prosthetic heart valve, coronary artery disease and cerebrovascular accident, that is stroke. Now, the drugs that are used are dicumarol 50 mg, finindione 5 mg or warfarin 5 mg. Now, mechanism of action of this drug is they interfere with the synthesis of vitamin K dependent clotting factor, that is factor 2, 7, 9 and 10. Okay, but you have to keep in mind that when you are giving anticoagulant therapy, the effect will not start suddenly. Okay, it will take some time. Okay, it will take some time for the anticoagulant to act on vitamin K and then decrease the factors. Okay, at the same time, when you are withdrawing the drug, it will take around 3 to 4 hours for the normal circulating clotting factor to disappear and the action to start again. Okay. Then the protocol that you need to keep in mind when you're treating an anticoagulant patient is do take a proper history and check the partial prothrombin ratio and international normalizing levels. Start the patient on antibiotic. Schedule the appointment within 2 days once the desired level is achieved. Okay, if the partial thrombin ratio is 1.5 to 2 and international normalizing ratio is 2 to 3, no need to stop or alter the drug. If the partial prothrombin ratio is 2 to 2.5 and international normalizing ratio is 3 to 3.5, dose can be altered with the physician guidance. If the prothrombin ratio is to more than 2.5 and international normalizing ratio is more than 3.5, delay your invasive procedure until your doses comes to normal. Decrease the dose so that the levels are normal. Now, you could always start the anticoagulation dosage regime in 48 to 72 hours, okay? Then let's move on to the antiplatelet drugs. The most commonly used, the brand name that we all know is aspirin. Patient takes around 75 to 150 milligram tablet, or clopidogrel 75 milligram tablet. Now, they basically inhibit enzyme cyclooxygenase and they prevent thromboxane A2 synthesis, which alter the platelet function. They basically affect the platelet plug formation. Okay, so platelet plug, the platelet do not adhere and form a plug, resulting in increase in bleeding time. Alright, but similarly you need to keep in mind that you need at least 2 to 3 days so that the platelet which is already there in the circulation to get disappear to have an antiplatelet effect. At the same time, when you are withdrawing it, you need to wait for 3 to 5 days so that the body produces sufficient amount of platelet to take care of the effect. Now, how do you treat the patient? Screen the patient, check the platelet function analyzer. The normal value is 60 to 120 seconds. Do an IV bleeding time test. The normal value is 1 to 6 minutes. Okay, only if the IV bleeding time is more than 20 minutes, then a clinically significant amount of bleeding can occur. Okay. Then at that time aspirin can be discontinued for 3 to 5 days. Let's move on to the respiratory system. Now, respiratory disease can be classified into obstructive pulmonary disease and infiltrative disease. Infiltrative disease are inflammatory changes in the alveolar wall, wherein obstructive disease are asthma, chronic bronchitis, pneumothorax, emphysema. Okay. Now, because of this respiratory disease, there is decreased pulmonary reserve, which eventually increases the risk for the procedures under general anesthesia. When you are treating a patient, always ask regarding the history, regarding the smoking, how many packets of smoking, from when the patient is doing smoking. Ask regarding the history of tuberculosis. If the patient gives history of tuberculosis, ask regarding whether the treatment has been complete or not. Okay, what all drugs were taken, whether the regime was completed or not. As we all know, tuberculosis is an infectious disease. We should always treat the patient after 6 months of their complete treatment. Then, preoperative investigations that are required: chest x-ray, pulmonary function test, blood investigations like arterial blood gas. Do a sputum examination for acid-fast bacilli and culture in case of suspected tuberculosis, bronchoscopy if required. Now, intraoperatively and postoperatively, you will manage or you will check the arterial blood gas monitor, both in case of major cases. Avoid fluid overload. Blood loss should be replaced by whole blood and packed cell to avoid decreasing the oxygen carrying capacity of the blood, which depend upon the hemoglobin present in the blood. Let's move on to the renal disease. Okay, now which are nothing but renal failure, acute glomerulonephritis, nephrotic syndrome. Now, because of this renal disease, there is change in the acid-base balance. Serum calcium and phosphorus levels are also affected. There is fluid retention, there is electrolyte imbalance. Most of the drugs are secreted towards the kidney. So you need to give drugs very carefully because even a small amount can cause an overdose. Now, preoperative investigation that is required is renal profile. That is, You have to do a complete renal serum creatinine, serum urea level, creatinine clearance level, serum calcium, phosphorus, urine analysis, USG of the kidney to see whether the size is increased and also any cystic degeneration, renal Doppler study if required. You intraoperatively and postoperatively, fluid balance, acid-base balance, electrolyte balance must be closely monitored. Do a renal function test periodically. Blood should be replaced with wash pack cells to decrease the load. Potassium overload during fluid replacement should be avoided. And give a broad spectrum antibiotic to prevent sepsis. Most commonly broad spectrum antibiotic that is used is amoxicillin, clindamycin. Let's move on to the next system, that is the hepatic system. Okay, ask the patient regarding the history of alcohol, drug abuse or hepatitis. Okay, we have to protect ourselves from hepatitis because it is infectious. It can be, for us, we are at main risk of hepatitis, a B and C carrier, which can spread through blood or body fluids. Now do a preoperative investigations. Liver enzyme, total bilirubin, direct and indirect bilirubin, serum albumin, serum alkaline phosphatase. Check the bleeding time and clotting time because liver synthesize vitamin K. Now vitamin K is important for many of these clotting factors like 2, 7, 8 and 9. Check for Australian antigen test. Then intra and post-operative management. Avoid any anesthetic gas that metabolizes in the liver like halothane. Now correction of the coagulation deficiency by giving IV vitamin K or fresh frozen plasma transfusion. Potassium replacement during fluid replacement. Okay, give potassium supplement. Precaution and sterilization technique should be maintained if you suspect that a patient is a hepatitis carrier. Then the next is the diabetes mellitus. Okay, we are all aware that diabetes is nothing but an abnormality in the production of insulin. It could be the diabetes 1 that is insulin dependent or diabetes 2 non-insulin dependent. Diabetes 1 is more commonly seen in young patients, whereas 2 is seen in case of the adult. Okay, you will consider a patient to be diabetic when the fasting glucose level are consistently above 140 milligram per day. Now what will happen if the level are high? Patient is more susceptible to infection. Patient can undergo into hypoglycemia, hyperglycemia or ketoacidosis. There is additional systemic problem associated with it. Like patient can have cardiovascular problem, can have peripheral vascular disease, can have heart problems, renal functions, ophthalmic problems. So there are other systemic complications associated with diabetes. Now what are the investigations that you need to do is chest x-ray, electrocardiogram, and the most important is blood sugar fasting as well as postprandial level, glucose tolerance test and renal perfusion. Do a urine analysis for sugar and ketone acetone bodies. Then in case you are doing procedure under local anesthesia, always opt for a morning appointment. Tell the patient to take the medicine and come. Do not skip the meal. Take either, if the patient is on insulin, take insulin, or an oral hypoglycemic, take oral hypoglycemic. If the procedure is done under general anesthesia, if the patient is on oral hypoglycemic, you will shift to insulin on the day of surgery. Provide at least 200 grams of carbohydrate with adequate insulin. Check the blood and urine sugar level every time during intraoperatively as well as postoperatively, and prepare a sliding insulin scale depending upon the blood glucose level. For example, if the blood glucose level is around 80 to 120, give plain 5% dextrose. If it is 120 to 180, 4 units of insulin in 5% dextrose. If 180 to 150, 8 units of insulin in 5% dextrose. Okay, 250 to 300, 14 units with 5% dextrose. If it is more than 300, then directly plain 14 units of insulin in normal saline. Then do not give dextrose. Now give a broad spectrum antibiotic that will take care of the infection. Close monitor the blood urine levels, blood sugar levels. Prevent the patient from going into ketoacidosis or hypoglycemia. Shift the patient as early as possible to regular oral feeds and oral hypoglycemic. Now, the main problem that arises in diabetic patients is hypoglycemia. Episodes can occur. What are the signs and symptoms of it? The patient will become apprehensive. Patient will become restless and agitated. The skin is moist, pale, and there is tachycardia. Eventually, they go into the coma. How will you treat it? If the patient is conscious, give oral glucose. If the patient become unconscious, give IV 50% glucose solution. The patient will regain its conscious within 5 to 10 minutes. If this doesn't help, give an IM 1 milligram of glucagon. The patient will eventually come to consciousness in 15 minutes. Now, in case of diabetic ketoacidosis, the patient will exhibit vomiting, tachycardia, Kussmaul's breathing. Kussmaul's breathing is nothing but air hunger. There is shallow respiration. There is a rapid and shallow respiration, dehydration, and circulatory collapse. Treatment is administration of insulin to normalize the body metabolism and restoration of the body fluid and electrolyte. There is basically metabolic imbalance takes place in ketoacidosis. Let's move on to the other system, that is the thyroid system. Now, the disease of the thyroid can be divided into hyperthyroidism, euthyroidism, and hypothyroidism. Euthyroidism is not of much problem, but when you're treating a patient, hyper and hypothyroidism can create a problem. Now, the signs of hypothyroidism is water retention. Patient is lethargic, there is bradycardia, there is decreased metabolic rate, and there is water retention in the body. The patient cannot tolerate very low temperature. Okay, whereas signs and symptoms of hyperthyroidism, there is increased hyperactivity, or you can say increased metabolic activity of the body. There is tachycardia. Okay, patient cannot tolerate heat at all. There is catabolic activity. This catabolic activity, if it is increased, it results in thyroid storm. That is increased metabolism for 24 to 48 hours, which will eventually result in hyperpyrexia and thyroid storm. Okay, what are the preoperative investigations that you need to do is that you have to check the thyroid hormone level, T3, T4 and TSH, whether they are normal or not, serum electrolyte and serum protein level. Intraoperatively, monitor the vitals, monitor the thyroid level, check for signs and symptoms of hypo and hyperthyroidism, monitor the cardiac function during the thyroid crisis. Thyroid storm, if it occurs, cool down the patient, give IV fluid, glucose and corticosteroids. In case of hypothyroid patient, the use of narcotic and anesthetic medication should be done cautiously because they can cause central nervous system depression. Now, let's move on to the management of hemophilic patient. Now, hemophilic patient is a hereditary disease. It is a sex-linked disease of a recessive variety, wherein hemophilia A is because of deficiency of factor 8 and B is because of deficiency of factor 10. Okay, now in hemophilia, for good hemostasis, the factor level must be 20% above the normal level. Otherwise, you have to transfuse or replace factor 8. Now, this replacement can be done in form of blood, plasma, fresh frozen plasma, cryoprecipitate. Anytime cryoprecipitate is preferred, but it is very difficult to get and it's very expensive. Now, how do you manage hemophilic patient? Okay, now build up the factor level 8 level up to 50 to 70%. Avoid any kind of deeper tissue injections. Rather than giving block, give infiltration. Use atraumatic extraction and surgical technique. Avoid unnecessary trauma to the soft tissue during surgery. Okay, don't do sutures if not required. Only if it is required, then opt for suturing. Then let's move on to the pregnant and lactating female. Now, female patient in a childbearing age should always ask regarding the history of pregnancy and missed menstrual cycle. Okay, if you are doing any procedure under local anesthesia, that can be done best during the second trimester, only if it is required. First trimester should be avoided because it can cause abortion, lot of stress and cause abortion, and it can have a teratogenic effect on the fetus. In the third trimester, LA procedure should be avoided because it can cause stress and produce premature labor and delivery. Okay, and if at all you have to do a general anesthesia procedure, you have to do in third trimester. That too, you have to see the risk and benefit must be overweight. Okay, for any kind of procedure. Before you do the procedure, explain the parents regarding the surgery, explain them regarding the benefit as well as the risk of the surgery, then only go ahead with it. Because you're not just treating the patient, that is the mother, but you're treating the mother as well as the fetus. Now, teratogenic drugs, that is tetracycline, salicylate, chloramphenicol, must be avoided. Rather, more friendlier and milder drugs are used like amoxicillin, chlorhexidine, ampicillin, paracetamol can be used. Let's move on to HIV or AIDS, the most talked about and the most dreaded condition in the world. Okay, acquired immunodeficiency syndrome is caused by human immunodeficiency virus. Okay, now this is a disorder of immune system in which the body normal defense system against infection is breakdown, leaving it vulnerable to host of life-threatening infection. Now, India is the second largest population in the world with HIV infected people. The first case to be identified in Chennai, then later on many cases were seen in different parts of the states, different states. Okay, now like any other infection, once infection occurs, body tries to fight against the infection and develop antibody against it. Okay, and it not only eliminate the infection but also it remember that if next time this infection occur, it has a more elaborate response. But this doesn't happen in case of HIV virus. HIV virus act on CD4 helper lymphocytes. Okay, they act on its cell and get incorporated into it, and it handle all the mechanism of the cell and start producing multiple virions. Okay, they start and eventually cell death occur. Okay, but here the body also have a response towards this, but the body response is comparatively slower than the amount of virions that are generated. At one hand, these viruses attack the immune system CD4 cells and destroy them. At the other hand, the body is not able to build up that immune response. So eventually the condition deteriorates until unless multiple systems of the body are affected. Now, the main systems that are affected is central nervous system, lymph, skin, gastric, liver, muscles, esophagus, pharynx. Okay, these are the symptoms that systems that are affected. Symptoms: patient can have fever, loss of weight within a short duration of time, malaise, headache, generalized lymphadenopathy, skin rashes, sore throat, there is sore esophagus, myalgia, enlargement of the liver. Okay, there is nausea, vomiting associated with it. Now, the modes of transmission of HIV is from unprotected sex from an infected person, from an infected blood transfusion. It could be through sharing infected needles from the infected person, or vertical transmission from a mother to the fetus can also take place. Now, the progress of the disease can be drawn into a flow chart wherein viral transmission, there is primary HIV infection wherein the virus incorporates into the CD4 cells. There is this termed as seroconversion. There is a clinical latent period with or without persistent generalized lymphadenopathy wherein the virus try to produce number of virions. Okay, eventually there is early symptoms of HIV infection wherein the CD4 counts start to decrease. Then AIDS is developed when the CD4 count is less than 200 per cubic millimeter, and advanced HIV infection occur when the CD4 count is much less than 50 per cubic millimeter. Now we as healthcare provider are more prone to get this disease from the infected person, either through body fluids, any of the body fluids. Okay, now steps that can be taken once you get exposed to HIV infection. If you have a needle prick injury, clean that area thoroughly with soap and hot water and put spirit or disinfectant agent. Okay, if there is splashes on the nose or mouth or skin, clean it with water, wash your face. It's better to wear protective eyewears. Okay, if there is a prick in the finger, do not put your finger in the mouth reflexively. Okay, so once you get exposed, report about the exposure and start the post-exposure prophylaxis within 2 hours. Okay, do not wait for 72 hours or 48 hours. As the time lapse increase, the effect of post-exposure prophylaxis decrease. After 72 hours, it has no effect. Then you will start with your basic regime of zidovudine, that is 600 milligram, okay, 2 times a day for 4 weeks, and lamivudine, that is 150 milligram, 2 times a day for 4 weeks. Now this basic regime can be supplemented with extended regime by adding Indiandentalacademy, 500 milligram 3 times a day. Then determine the HIV status of the source that from you have infected so that you can treat yourself properly. do a continuous testing, that is HIV, Western blot test, and your counseling and the time of exposure after 6 months and after 12 weeks. Then the protocol of treating HIV patient. Okay, you begin with the theatre. First of all, you will post the HIV positive patient case the last. It will be the last case that you will operate on. Okay, and that too you will put a plastic sheet, that is on top of that you will put a linen, and then you will place your patient on top of it. Okay, now intubation and complete extubation of the patient should be done in the operation theatre only, because if there is any kind of infection, it will be there in that one room. Okay, then use minimal instrument. All additional instruments should be avoided or should be removed. Okay, keep less person in the room so that you do not contaminate other person. If you require a circulating nurse, keep the circulating nurse outside the door, okay, so that you could communicate, but keep as less person in the room as possible. If there is any kind of spillage of the blood, okay, put 2% sodium hypochlorite for 30 seconds, then mop it with disposable towel and then incinerate it. Then regarding the instrument, those instruments that are autoclavable, you autoclave it first, then let it cool, then wash and scrub in hot water, and then again re-autoclave it. Okay, if it is non-autoclavable instrument, then what you could do is immerse it in 2% glutaraldehyde for 1 hour, remove it, clean it, scrub it with hot water, and again immersed it in glutaraldehyde for 3 hours. Okay, sharp needles should be disposed properly, and laboratory specimens should be labeled as biohazards and put into a 2 to 3 plastic containers so that any kind of spillage is avoided. Now, disinfectant that can be used to disinfect surfaces or tissues from HIV virus infection are freshly prepared sodium hypochlorite 1% for 30 minutes, glutaraldehyde 2% for 30 minutes, formaldehyde 5% for 30 minutes, ethyl alcohol 70% for 60 minutes, isopropyl alcohol for 30 minutes, and freshly hydrogen peroxide 3% for 60 minutes. With this, I would like to conclude by saying that maintain a protocol when you're managing the patient. That is, take a proper case history. Ask the patient regarding the medication, regarding the regularity of medication. Take a proper consent from the patient. Inform the patient regarding the risk and benefit of the surgical procedure. And in your surgical procedure, keep all life-saving measures ready, because the decision of whether to operate or not is ultimately lies in the hands of the surgeon. Thank you.